Welcome back to the deep dive. Today, we're plunging into a world that, at first glance, seems incredibly clear, but is actually full of these fascinating optical illusions. You've undoubtedly seen an ultrasound image, perhaps for a diagnostic scan, or maybe even a beautiful baby reveal. They look straightforward, don't they? But what if I told you that sometimes what you see isn't exactly what's truly there? We're talking about ghosts on the screen phenomena that can either lead you astray or, if understood, provide invaluable diagnostic clues.
Yeah, and what's truly fascinating about these visual anomalies is that they're far more than just, minor glitches. Misinterpreting them can have profound clinical ramifications. We're
Hmm.
talking about situations that could lead to misdiagnosing life-threatening conditions like an aortic dissection or, say, a ventricular thrombus. And that could potentially trigger unnecessary invasive procedures, incorrect antibiotic prescriptions, even more costly follow-up imaging like CT scans. This isn't just academic. It directly impacts patient safety and the efficiency of our healthcare system.
Okay, so our mission for this deep dive is really to unmask these ultrasound artifacts. We're going to help you understand precisely why they appear, how to confidently spot them, and critically, how to turn what seem like image errors into powerful diagnostic insights. Think of it as learning the secret, nuanced language of ultrasound.
And that raises a crucial question, doesn't it? Are these artifacts always a problem to be avoided? Well, absolutely not. We'll delve into how many of these, when correctly interpreted through a deeper understanding of the underlying physics, can actually convey invaluable information about tissue composition. This transforms them from simple nuisances into essential components that truly enhance clinical utility. It's a nuanced understanding that moves well beyond just, reading the surface of an image.
So, why do these artifacts even exist then? Where do they come from?
It really comes down to some fundamental, almost simplistic assumptions the ultrasound machine makes. Imagine the system is playing a very sophisticated game of Marco Polo in a completely dark room. The machine assumes sound always travels at a constant fixed speed, typically set at 1,540 meters per second for soft tissue. It assumes sound travels in a perfectly straight line. It assumes sound attenuates or weakens uniformly as it passes through tissue. And crucially, it assumes all echoes received originate from the precise center of its main sound beam. But here's where it gets truly counterintuitive. What happens when those perfect world assumptions are shattered within the incredibly complex, varied landscape of the human body?
Ah, that's where the magic or sometimes the mischief begins. If we connect this to the broader principles of imaging, well, when the sound beam encounters tissues where the speed of sound is markedly different from that assumed 1,540 meters, perhaps it's much faster through bone or slower through fat.
Or if the sound wave bends, which we call refraction, or if it's completely absorbed by a dense structure, the machine still applies its perfect world calculations.
Ah.
This discrepancy between the machine's assumption and physical reality is the root cause of nearly every artifact. For instance, if sound travels slower through a fatty lesion, the machine will calculate a longer travel time and thus display the structure as being deeper than its actual anatomical position. That's what we call a speed displacement artifact. Understanding this fundamental physics transforms a confounding image into a valuable diagnostic clue. It moves us beyond simple pattern recognition to true comprehension.
Right, and it's not just about the machine's inherent assumptions, is it? How much of this responsibility or maybe opportunity falls onto the operator, the sonographer, the radiologist, physician using the machine?
That's an excellent point. The operator is a pivotal part of this equation. While artifacts are inherent to the physics, yet improper device settings or maybe suboptimal scanning techniques frequently contribute to their generation. Or worse, to their misinterpretation. This really underscores the necessity for a truly comprehensive grasp of the ultrasound equipment's functionality, its strengths, and its limitations.
So it's about being an active participant in the image creation, not just a passive observer.
Exactly. The expert's ability to judiciously adjust parameters like overall gain, the wall filter which controls low-frequency noise, or the velocity scale for Doppler imaging. This directly influences the complex interplay between the sound waves and the tissue. This transforms the expert from someone who merely interprets an image into an active architect who optimizes image acquisition in real time, often mitigating artifacts before they even become a diagnostic puzzle.
All right, let's dive into some of the most common grayscale artifacts you'll encounter in your daily practice. You'll quickly see how easily these can lead to serious misinterpretations if you're not fully tuned into the nuances of what you're seeing. Maybe we can group some of these by the principle they violate, make them stick a bit better.
Good idea. Let's start with a classic set of illusions, often caused by sound bouncing off highly reflective surfaces. First up, the mirror artifact. Imagine seeing a perfect ghost-like duplicate of an organ, perhaps the liver, appearing where it simply shouldn't be, sometimes even floating above the diaphragm.
Wow.
This happens when a highly reflective surface, like the diaphragm, acts like an acoustic mirror, balancing sound back and forth. The system then mistakenly thinks these echoes are coming from deeper structures, creating that false, duplicated image symmetrically beyond the strong reflector. You'll most often see this on the right side, with the liver or maybe the spleen.
So it's essentially the machine getting confused by an echo's longer journey, and I imagine this can be pretty misleading clinically.
Precisely. A common pitfall is mistaking this duplicated liver image for actual lung consolidation,
Oh, right.
which could lead to unnecessary antibiotics, x-rays, or even more costly CT scans. To prevent this, you always integrate the clinical picture. Does the patient have symptoms of pneumonia? You look for an identical tissue pattern in the duplicated image, and critically, the absence of real signs like pleural effusion or air fluid bronchograms.
Okay.
And a simple technique. Try scanning with an oblique orientation. The artifact often disappears or changes significantly.
Got it. So change the angle. What about other reflection issues?
Building on that theme, we have reverberation artifacts. These are incredibly common. They occur when sound bounces repeatedly between two parallel, highly reflective surfaces. Think of it like a persistent echo in a small resonant room, almost like a ping pong effect.
Oh, okay.
This creates multiple, equally spaced parallel lines or bands extending deep into the image. You might recognize them as a comet tail or a ring-down appearance.
I can picture that. And these, I hear, aren't always a problem. Sometimes they're useful.
That's a key insight. While they can certainly mimic a mass, especially in a fluid-filled structure like the bladder, reverberations, importantly and directly, indicate the presence of highly reflective parallel interfaces, things like air or metal fragments, dense calcifications, even certain cardiac devices. The artifact itself is a valuable clue, telling you precisely what's causing it.
So the artifact is the information.
In many cases, yes. Often simply changing your angle of insonation, that's just the angle at which your sound beam strikes the tissue, can disrupt those parallel reflections and resolve the artifact, or at least change its appearance, confirming what it is.
Makes sense. What about artifacts from the transducer itself?
Right. Transducers themselves, in their very design, can create subtle distortions. We're talking about side lobe and grating lobe artifacts. You see, while the transducer aims its main sound beam straight ahead, it inherently emits small amounts of energy off-axis, like faint ripples spreading out from the main wave.
Okay, little bits of energy going sideways.
Exactly. If a strong reflector, say a bladder wall or even bowel gas, happens to be in one of these off-axis side lobes or grating lobes, the system incorrectly places its echo back into the main image along the central beam path. This can appear as misplaced or duplicated structures, maybe pseudo-mud or sludge in the bladder or gallbladder that isn't really there, or even linear arc-like artifacts that might mimic something serious, like a dissection flap. It's an inherent limitation of transducer design, really.
So the machine's straight line assumption gets tripped up even by its own subtle emissions. That's tricky.
It is. To mitigate these, you need to optimize your US image settings, things like gain and TGC. Ensure proper focal zone placement that helps narrow the beam. And crucially, use multiple scans from slightly different angles to confirm or deny the presence of a structure. If it disappears or changes drastically with angle, it might be a lobe artifact.
Okay, multiple angles are key. Let's shift gears slightly. What about when the sound beam itself gets bent?
Now you're talking about refraction artifacts. These occur when the ultrasound beam bends as it passes through an interface between two media with different speeds of sound. Think of how a spoon looks bent when you put it in a glass of water. The light bends. Same principle with sound waves crossing boundaries, like between fat and muscle.
Right, the classic bent spoon analogy.
Exactly. This bending can misregister structures laterally, or even create a duplicate object. Sometimes you see a double image of the aorta, or a vessel might appear to have a notch or a kink where it's actually straight.
That sounds like it could cause some serious diagnostic confusion. A double aorta.
It can be very serious. That double image of the aorta, for instance, could absolutely be misinterpreted as a dangerous aortic dissection. Or a displaced image of a kidney boundary might mimic a traumatic kidney rupture. A single 2D image is often insufficient for accurate diagnosis here. The key mitigation is performing scans with multiple planes, coronal, axial, and sagittal views. These orthogonal perspectives help you truly discern the real anatomical relationships versus the artifactual displacement.
Multiplanar scanning again. Seems like a recurring theme.
It's fundamental for dealing with spatial ambiguity. Now, closely related to refraction is speed displacement. or propagation velocity artifacts. This happens when sound travels at a non-standard speed, meaning it's different from that assumed 1,540 meters per second the machine uses for calculations.
Right, you mentioned fat is slower, bone is faster.
Exactly. When the machine calculates depth, it uses time distance speed, rearranged to distance speed time. It assumes a constant speed, 1,540 meters. So if the sound actually traveled slower through a fatty tumor, for example, the time to return is longer. The machine, using its fixed speed, calculates a greater distance.
So it places the structure deeper on the screen than it really is.
Precisely. And the opposite happens if sound travels faster, like through certain dense tissues, it appears shallower. While often subtle, this artifact is clinically significant for precise measurements or lesion localization, especially near interfaces of tissues with very different speeds.
I can see how that would matter for biopsies or treatment planning.
Definitely. Think about trying to precisely measure a tumor within adipose tissue versus dense muscle. The machine's assumption can subtly shift its perceived location and size. Mitigation is limited, but being aware of the surrounding tissue types helps. Multiple scans or sometimes using specific tissue velocity presets, if available, can offer a better assessment of true depth.
Okay, now you mentioned earlier some artifacts aren't just noise, they're actually signals. Let's unpack those. That sounds really interesting.
Yes, this is where the paradigm really shifts. We're talking about attenuation artifacts, which include acoustic shadowing and posterior acoustic enhancement. They tell you about how much the sound is weakened as it passes through tissue. First, acoustic shadowing. This occurs when the ultrasound beam encounters a highly attenuating or reflective structure, something so dense or hard that it blocks or reflects most of the sound, preventing it from reaching deeper areas. It appears as a hypoechoic or essentially dark, black signal void area immediately deep to the structure.
So it's literally casting a sound shadow. What does that shadow tell us? What's causing it?
It's an invaluable diagnostic sign. That shadow is practically shouting calcification, or stone, or bone, or maybe metal. It's a crucial indicator of dense structures like gallstones, urinary stones, calcified plaques, bone fragments, or metallic foreign bodies. It's not an error to be corrected. It's a direct piece of information about the tissue composition right there on the screen.
Okay, so shadowing means dense. What's the opposite?
Its counterpart is posterior acoustic enhancement, sometimes called increase through transmission. This happens when the beam passes through a structure with very low attenuation, meaning it barely absorbs or scatters the sound. Think of a perfectly fluid-filled cyst.
Right, sound goes right through it easily.
Exactly, because less sound energy is lost in that superficial structure, the echoes returning from the tissues deeper to it are relatively stronger compared to adjacent areas at the same depth. This results in a hyperechoic or brighter appearance in the region immediately deep to the low attenuation structure.
So the easy passage results in a brighter signal below. What does that signal?
This is a strong indicator of fluid-filled structures, things like simple cysts, bursitis, ganglion cysts, hematomas, abscesses, or joint effusions. It's incredibly useful for distinguishing between solid masses and simple fluid collections.
Very useful. Can it be too bright sometimes?
It can. If this enhancement is so bright it's obscuring other structures you need to see deeper, you can decrease the gain specifically in that deeper region using your time gain compensation, or TGC controls. But the key takeaway for both shadowing and enhancement is this. These attenuation artifacts are diagnostically invaluable. They are inherent properties revealed by the physics, not errors to be mitigated, and they provide real-time critical information about tissue composition, often preventing the need for further, more expensive imaging studies.
That's a really important point, artifacts as information. What else falls under grayscale issues?
Well, there's beam width artifacts. We know the ultrasound beam isn't an infinitely thin line, it has a finite width, especially outside the focal zone. This means echoes are collected from a volume, not just a single precise line. This leads to decreased lateral resolution. What does that mean in practice? It means small or closely spaced lesions can be difficult to resolve separately. They might blur together. Or objects that are slightly outside the intended scanning plane can be incorrectly displayed within it, creating a kind of partial volume effect.
So the image isn't perfectly sharp on the sides and things can kind of bleed into each other visually.
Exactly. It's a fundamental limitation of the technology related to transducer physics. Mitigation strategies include careful manipulation to the focal zone, adjusting where the beam is narrowest to the depth of interest, and performing multiplanar assessments to confirm findings and separate structures.
Okay, and what about that grainy texture we always see? Speckle.
Right, speckle artifacts. These manifest as that characteristic granular textured appearance on your screen, especially in solid organs like the liver or thyroid. This noise isn't truly random. It's actually caused by the constructive and destructive interference of scattered sound waves returning from within the tissue itself. These waves bounce off countless tiny scatterers like cells and small fibers that are smaller than the ultrasound wavelength. The returning echoes interfere, creating this complex pattern.
So it's not random noise, but a pattern created by the sound waves interacting with the tissue's fine structure.
That's right. Think of it like the complex patterns you see when light waves interfere, or ripples on a pond crossing paths. Sometimes they add up, making bright spots. Sometimes they cancel out, making dark spots, creating this unique granular signature for different tissues. While often considered unwanted noise that can obscure small details, speckle actually provides nuanced information about tissue texture. And it's leveraged by advanced techniques like speckle reduction imaging, SRI, which try to smooth it out to improve overall image quality, but the raw speckle pattern itself contains information.
Interesting. Now, one I know trips people up a lot, especially in MSK, anisotropy.
Ah, yes, anisotropy. This is a huge one in musculoskeletal ultrasound. It occurs when the ultrasound beam strikes highly organized, linear, fibrillar structures, think tendons and ligaments, primarily at an incorrect, non-perpendicular angle.
Non-perpendicular, so not hitting it straight on.
Exactly. Because these fibers are so highly ordered and directional, if you don't hit them at 90 degrees, the sound waves are reflected away from the transducer, specularly, instead of backscattered towards it.
So if you don't hit it straight on, the sound just bounces off and goes somewhere else, and the machine thinks nothing's there.
Precisely. This results in an aberrant, hypoechoic, or darker zone within the structure. It can look exactly like a tear or tendinosis or maybe a fluid collection when the tissue is perfectly normal and healthy. This artifact is almost entirely operator-dependent. The crucial mitigation is always adjusting your angle of inclination to be strictly perpendicular to the fibrillar structures. You have to literally rock or toggle the transducer dynamically to find that sweet spot where the fibers appear brightest and most uniform. If that dark area disappears when you're perpendicular, it was anisotropy.
Critical technique point there. Rock that probe. Okay, one last grayscale one. Image adaptation.
Right, image adaptation artifacts. These are a bit more subtle and somewhat paradoxical. They're a consequence of the very real-time image processing methods designed to improve image quality. Things like edge enhancement filters, which sharpen boundaries, or spatial compounding, which averages frames from slightly different angles. These are generally beneficial, but they can inadvertently create artifactual, hypoechoic lines, dark lines, that run parallel to highly reflecting interfaces.
So the software meant to make things clearer can actually introduce new, confusing elements, like fake fluid lines.
Potentially, yes. It's a bit of a double-edged sword. These artifactual lines might simulate thin fluid collections or maybe subtle delaminations, leading to misinterpretation. It requires an awareness of how these sophisticated processing algorithms work, how they can subtly alter the raw data, and what their potential side effects might be. It emphasizes that even as technology advances, continuous learning about how the machine truly works remains vital for accurate interpretation.
Absolutely. Okay, let's transition now. Doppler ultrasound is incredibly powerful for assessing blood flow velocities, direction, character. But just like B mode, it introduces its own specific set of artifacts. And here I imagine the stakes for technical parameters and operator skill are perhaps even higher, given the dynamic nature of blood flow.
Absolutely. The physics is more complex, and the settings interaction is critical. One of the most intriguing and often misunderstood Doppler artifacts is the color Doppler twinkling artifact. This appears as a distinct, rapid color flash, almost like shimmering Christmas lights, a mixture of red and blue behind a strong, granular reflector, like a stone, even though there's no actual blood flow there.
No flow, but it lights up like a Christmas tree. Why?
The exact mechanism is still debated, maybe involving micro-bubble resonance trapped in the crevices of the rough surface, or complex scattering, but it's highly dependent on machine factors, your focal zone placement, grayscale gains, color right priorities, and pulse repetition frequencies, or PRF.
That sounds confusing, but I've heard it can be quite useful, right?
Indeed. Despite being an artifact, it's considered a useful additional sonographic sign. It's particularly valuable for diagnosing calcified lesions, urinary stones, biliary stones, and even conditions like gallbladder adenomyomatosis. It's almost as if the stone is sparkling to announce its presence, especially helpful for small stones that don't shadow clearly.
So you can use the artifact to your advantage.
Exactly. And you can actually adjust those machine parameters tweak the focal zone, adjust the gain, lower the PRF, change the color right priority to either enhance its appearance to make it more obvious or mitigate it if it's obscuring something else.
Interesting. What about more mundane Doppler problems, settings
Oh
issues?
yes, other key Doppler artifacts stem directly from inappropriate equipment settings. This is huge. For example, if your wall filter is set too high.
The wall filter cuts out low velocities, right, like tissue motion.
Exactly. But if it's set too high, it will also eliminate crucial low-velocity blood flow, potentially making a patent vessel look occluded, or missing subtle flow in a tumor or inflamed tissue. Conversely, excessive color gain can introduce so much noise it creates color bleed, making it seem like flow extends outside the vessel walls, potentially masking a real stenosis or making a vessel look larger.
Got it. And what about aliasing? That's a big one in Doppler, isn't it? Seems to happen all the time.
It is very common. Aliasing occurs when your pulse repetition frequency, PRF essentially, how often the machine sends out sound pulses to measure velocity, is set too low for a very high velocity flow, like in a tight stenosis. The machine can't sample fast enough to correctly measure the peak velocity. The color appears to wrap around the color bar, showing flow incorrectly appearing in the opposite direction, ARG blue appearing within a red jet. Or on spectral Doppler, the top of the waveform gets cut off and appears at the bottom.
So how do you fix aliasing?
You need to increase the Nyquist limit, which is half the PRF. You can do this by directly increasing the PRF or scale setting. You can shift the baseline up or down. You could switch to a lower frequency transducer, which has a lower Doppler shift for the same velocity. Or sometimes using continuous wave Doppler, which doesn't alias, though it lacks range resolution. The general mitigation for most Doppler setting issues is to carefully and appropriately adjust your gain, wall filter, and velocity scale, PRF, for the specific vessel and flow conditions you're interrogating. It's not one size fits all.
Makes sense. Do we see mirror images in Doppler too?
We do. Just like in B mode, we also encounter the Doppler mirror image. This is where the reflection of the Doppler signal, usually have a strong reflector like the pleura or diaphragm, creates a false duplicated vessel or flow signal. It might seem like there are two vessels when there's only one, or flow in a side branch that doesn't exist, mirrored across the reflecting interface.
And the fix is the same. Change the angle.
Pretty much. Change your angle of inclination to avoid the strong reflector causing the mirror. Also, reducing the Doppler gain can sometimes help diminish the artifactual signal.
Okay. And finally, the angle itself is critical in Doppler, right?
Critically important. We must consider angulation effects. The accuracy of velocity measurements in Doppler ultrasound is highly dependent on the Doppler interrogation angle. That's the angle between your sound beam and the direction of blood flow. The machine uses the Doppler equation, which includes the cosine of this angle. As the angle approaches 90 degrees, the cosine approaches 0.
Meaning the measured velocity approaches 0 even if the flow is fast.
Exactly. Angles approaching 90 degrees relative to flow severely degrade the signal quality, lead to inaccurate velocity measurements, underestimation, can overestimate turbulence, and even cause directional ambiguity, making it seem like flow is bidirectional when it's unidirectional. You might even lose the signal entirely.
So if your angle is bad, your velocity readings are essentially unreliable, which is critical for diagnoses like stenosis grading.
Absolutely critical.
Mm.
The golden rule is to optimize your angle, always maintaining it below 60 degrees relative to the flow direction to ensure accurate and reliable velocity measurements. Steeper angles, closer to 0 degrees, parallel to flow, are ideal, but often not achievable. So 60 degrees is the practical upper limit. And remember those side engraving lobes we talked about in B mode. They can also pick up Doppler signals from adjacent vessels or moving tissue, introducing extraneous Doppler information like color flow appearing outside the vessel you're interested in. So again, adjusting settings, focusing, and confirming with multiple views remains important across both B mode and Doppler.
Okay, that's a comprehensive tour of the pitfalls. So we've thoroughly covered the ways artifacts can trip you up. But let's circle back to that really fascinating idea that these errors might actually be giving us unique, invaluable information. What's the biggest misconception we need to reframe here?
Yeah, that's the pivotal shift in thinking, I believe. The biggest misconception is viewing artifacts solely as impediments, as noise to be eliminated. A sophisticated understanding transforms them from mere challenges into powerful diagnostic tools. Let's think about some really compelling examples. Attenuation artifacts, which we discussed earlier, are prime examples.
Right, shadowing and enhancement.
Take acoustic shadowing. Imagine you have a patient presenting with, say, acute right upper quadrant pain, and you're concerned about gallstones. You scan the gallbladder, you spot a hyperechoic structure in the lumen. Okay, could be a stone, could be sludge, could be a polyp. But then you see it casts a distinct, sharp, dark shadow behind it. That shadow isn't just a defect, it's definitive proof of a dense, sound-blocking structure. Without that shadow, a simple hyperechoic spot is ambiguous. The shadow confirms stone, providing immediate, crucial information that guides treatment, potentially avoiding unnecessary follow-up tests or delays.
So the shadow itself is the key diagnostic feature, almost like the finding itself.
Often, yes, it's a positive sign. Similarly, posterior acoustic enhancement is equally diagnostic, just in the opposite way. Consider a patient with a palpable lump, maybe in the breast or soft tissues. Your ultrasound shows an anechoic, black, fluid-filled structure. But what distinguishes a simple benign cyst from perhaps a complex cyst or even a solid hypoechoic mass? The presence of clear posterior acoustic enhancement, that brightness deep to the structure, tells you that sound is passing unimpeded through it. This strongly reinforces the likelihood of it being a simple fluid-filled cyst. This instant tissue characterization, derived directly from the artifact, often negates the need for further, more expensive imaging like an MRI, or invasive procedures like fine needle aspiration for a simple cyst.
It provides confidence in the benign nature right away.
Exactly. And that color Doppler twinkling artifact we talked about, despite being purely an artifactual phenomenon generated by the machine interacting with a rough surface, it's a remarkably sensitive sign for stones. If you're scanning a kidney and see a suspicious echogenic focus, maybe too small to cause definite shadowing, the appearance of that characteristic twinkling behind it can dramatically increase your confidence that it's truly a calcified stone, rather than just a vessel crossing or renal sinus fat. This is a real game changer for conditions like nephrolithiasis, kidney stones, where early accurate identification of even tiny stones is key for management. This represents that significant shift in diagnostic thinking. Artifacts, when correctly decoded based on their underlying physics, provide unique and invaluable information that can streamline diagnosis and enhance patient care.
That's powerful. So let's bring it all together. How do you, as a sonographer, radiologist, or physician using ultrasound daily, truly master this intricate language of artifacts? It sounds like it's not just about passive recognition, but actively managing them. It requires a multifaceted approach, doesn't it?
Absolutely. It's an active, dynamic process. First, and maybe most fundamentally, optimizing equipment settings is crucial. It's about knowing your machine inside out, not just the basic knobs. A thorough understanding of your specific machine's functionality allows you to systematically configure the correct system settings and Doppler parameters for the task at hand. For instance, skillfully adjusting the gain, maybe using PGC to decrease gain specifically at deeper regions, can reduce problematic posterior enhancement if it's obscuring underlying structures. Or ensuring correct transmit power, frequency selection, and focusing can drastically improve issues arising from side lobes or beam width. And as we discussed, precise Doppler adjustments, PRF, wall filter, gain, baseline, are absolutely critical to avoid losing vital flow information or introducing false signals. This proactive control is fundamental.
So know your instrument intimately. What's next?
Second, advanced scanning techniques are essential. You can't just put the probe down and accept the first image. Many artifacts can be mitigated or even completely eliminated through dynamic real-time adjustments by the operator. For example, as we mentioned, simply changing your angle of inclination can resolve reverberation and mirror artifacts by disrupting those parallel reflections or moving the mirror out of the path. For refraction artifacts, performing those coronal, axial, and sagittal views provides orthogonal perspectives, allowing you to discern true anatomical relationships versus spatial distortions. And for anisotropy in tendons and ligaments, strictly adhering to that principle of perpendicular inclination, literally rocking or toggling your transducer constantly to make the beam hit those tendon fibers at exactly 90 degrees, is vital to avoid misdiagnosing normal anatomy as pathology. This highlights the truly interactive nature of ultrasound. You're not just looking at a static image, you're actively creating and optimizing it in real time.
Right, you're sculpting the image as you scan. And the final piece.
Third, and perhaps most importantly, is integrating the clinical picture and patient history. Even with perfect technical skill and artifact recognition, the final diagnostic decision always hinges on correlating the imaging findings with the patient's symptoms, medical history, lab results, and other clinical data. For example, that mirror artifact mimicking lung consolidation we talked about. It can be confidently differentiated by the absence of clinical signs of pneumonia, no fever, no cough, clear lung sounds, or maybe the lack of pleural effusion on the image itself. The image alone is often insufficient. It demands a holistic diagnostic approach. You're not just interpreting pixels, you are solving a clinical puzzle for that specific patient.
Excellent point. It always comes back to the patient. And briefly, what about newer technologies? Are they making this easier, or are they introducing new complexities we need to watch out for?
That's a great question, and honestly, it's a bit of both. Newer modes like spatial compounding, which averages images acquired from slightly different angles, and speckle reduction imaging, SRI algorithms, they certainly enhance overall image quality, smooth out noise, and can reduce certain artifacts like shadowing or enhancement sometimes. However, as we saw with those subtle image adaptation artifacts, they can also introduce their own, sometimes unexpected, machine-induced phenomena. They alter the raw data. This means continuous learning is absolutely essential for experts. You need to understand how these sophisticated algorithms work, how they might subtly change what you're seeing, and what their potential side effects or new artifact patterns might be. It's an ongoing dance between embracing technological advances and maintaining critical interpretation skills.
What a deep dive. We've journeyed through the subtle and sometimes not so subtle world of ultrasound artifacts. You've learned that these phenomena are truly inherent to the imaging process itself, born from the physics. They can be confusing, yeah, a deceptive visual trick at times, but as you heard, understanding them fundamentally transforms them from mere noise into incredibly valuable signals that can tell you things no other imaging modality can, often in real time, right at the bedside.
And this truly raises an important question, I think, for you, the expert sonographer, the radiologist, the physician listening. How will this deeper understanding of the underlying physics, combined with meticulous dynamic scanning techniques and thorough clinical correlation, how will this allow you to not just interpret images, but truly master the art and science of ultrasound diagnostics? It's really a continuous journey of precision, critical thinking, and ultimately a profound responsibility to assure optimal patient care by getting the diagnosis right.
Something to mull over as you approach your next scan, isn't it? Understanding the ghosts on the screen might just lead you to the clearest diagnosis. Thank you for joining us on this deep dive.